Our
Thank you, ma'am.
discussions.
Yeah, thank you very much, ma'am. So once again, on behalf of ARC, I welcome all the honorable expert panel and our esteemed debaters. So it is said that there are no tough opponents in debate, but only tough issues. So one such tough issue is when a 60-year-old patient with +3 diopter of refractive error and a clear lens comes to you. So would you go for a presbyopic lens exchange and premium IOL implantation, or you would like to wait for the cataract to develop? So this will be debated by Dr. ARULMOZHI VARMAN, who is one of the pioneer in Indian ophthalmology, heading his very popular UMA Eye Clinic at Chennai. And up against him is Dr. Madhukar Reddy, who is a very prolific cataract surgeon with a great practice in his Drishti Eye Center in Amirpet, Hyderabad, and who holds the vision that the cataract has to develop before he undergoes the surgery. And so first, let's hear it from Dr. ARULMOZHI VARMAN. Over to you, Dr. VARMAN.
Thank you, Ashok.
Mr. Sunil, watch the time, please.
And thank you, Chitra, for asking me to speak on this topic. Chitra, when you introduced the whole program, you said this is controversial. You have 10 topics that are being debated. But I think this one is the least controversial. It's just an open shut case. You have a 60-year-old +3, it's pre-meds. Let's see, there's no controversy here. I'll digress a bit here. Dr. KK missed out an important point. Atishwar waxed eloquent about the Indian lenses. But when he put up his last slide, you had his hospital up there, and what was parked in the car park was a BMW, not a CS. Let's go now. Now, what happens to a person who was 60? He's already 60, he's into his 6th decade and having a lot of other issues. But then you put him, give him a +3 hyperopia. He can't see distance. He can't see near. He wakes up in the morning. He wants to see the time. The wall clock is not clear. He looks around and looks at his watch, or today we are looking at our cell phone. Lo and behold, he can't even find the cell phone. He's blind as a bat. He's got to flumble around and flounder till he finds a pair of spectacles, puts them on, maybe knocks over. We just think that this is a male, poor old male, 60 years old with +3, and he knocks over things on the table or the side table, and then wakes his wife up and gets fired. He's got to go and brush his teeth. He can't see the toothbrush without his glasses on. He can't shave. He can't do a damn. So you have this person who's now visually incapacitated, 1. 2, there are enough and more studies that show that there is a progressive reduction in the anterior chamber depth as we age. Simple as that. This is just cannot be questioned. This has been there with all the races across the country, across the world. There is a very clear relationship between the refractive error and anterior chamber depth. You're a myope, you have a deeper chamber. You're a hyperope, you have shallower chamber. You keep growing older, the chamber gets more shallow. So we also have correlation that shows correlation between shallow and anterior chambers and iridotrabecular contact. In other words, angle closure. Very clear. There are umpteen number of studies that will tell you if you're hyperope of 3 and you're 60, you already have chances of an iridotrabecular contact, and you're a prime candidate for an angle closure somewhere down the line. This is increasing incidence of angle closure with reduced AC depth and axial length. Axial length reduces, your axial, the anterior chamber depth reduces with age. The lens keeps getting more thicker as we grow. There's one of the parts in the body that keeps growing, just like your ear and your nose, the lens keeps growing. So that keeps getting bigger and you have less and less space. So we will have definitely, Madhukar will tell you that let's do an YAG iridotomy and this guy is going to be fine. There are studies that show you a minimum of 28% or even sometimes more proceed to angle closure even after a YAG PI. So doing a PI is not going to save you from angle closure or a slow chronic angle closure, acute angle closure, or going in for an angle closure glaucoma. 30% of your patients are probably going to progress into that in spite of the PI. On the other hand, you take out this 5 millimeter thick natural lens and put in a 1 millimeter thick artificial lens. Your whole anterior chamber, the anterior segment becomes absolutely normal. It widens out, completely takes away the chance of any kind of angle closure. So you're now saving this person not only from the chance of angle closure or glaucoma, also giving him much better vision. Then we'll also talk, my opponent, Madhukar, will also talk to you about risk of RD. Risk of RD is more with longer eye lengths. A +3 is probably having a shorter length, the chance of RD comes down. If you have studied the periphery of your retina before you do the surgery and continue following these patients up, the chance of RD is definitely much lesser. I won't even get into the chances of endophthalmitis. With today's technology, with the kind of technique of maintaining sterility that we have in our instruments and in our theater, it's not very difficult for us to achieve less than 1 in 10,000 ENDOFs in the long run. With such low incidence of ENDOF, I think we shouldn't even be discussing ENDOF as a possible complication. RD after phaco in shorter eyes is extremely less, as the graph will show you straight away. The procedure is very simple. All we need to do, this is something that you can probably, you have a clear lens. The lens is not going to be very hard. Just going to make it so simple for anybody who's a reasonably good phacosurgeon to do a great job with least difficulties. You're not going to go and damage endothelium. You're not going to get a PCR that easily. You're not going to have any other issues. This is going to take you hardly about, actually for an experienced surgeon, the whole surgery start to finish will probably about 4 to 6 minutes. You have a nice soft cataract, but you do have a nice, good nucleus in the center, which will definitely break. You can do a chop if you wish to. And the rest of the cataract just comes off in a matter of a minute or minute and a half. That leaves you with the freedom to implant an appropriate advanced lens that would take away the dependence on glasses of this gentleman and give him good vision. We'll come to the high accuracy of calculation. So the Keiki put up this web source IOL master, the technology that look after absolute accuracy. The performance of the IOLs that we have today, the trifocals, the quadrifocals, the EDOF plus trifocals that are in the market are so brilliant. The quality of vision is clear over all distances. The clarity is very good. The contrast sensitivity is simply excellent and with minimal photic phenomena. So what do you offer to these patients? You give them the relief from disturbance of hyperopia, you give them natural vision, and an absolute relief from angle closure down the line. What are you going to gain by waiting 5 years? Nothing. You're only going to wait till the patient or the person develops cataract. In the meanwhile, the risk of this person developing angle closure is going to be very high. He could go in for a harder nucleus, making his surgery more difficult. So Prelux is the way to go in hyperopia in the 6th decade. There's nothing else. And I would thank you for listening to me. Let's listen to now Madhukar.
Thank you very much, Dr. Varman, for putting your side of this